Welcome to the Healing My Parts podcast, a podcast dedicated to educating and raising awareness about dissociative identity disorder, also known as DID. We are your hosts, the system behind Healing My Parts, which also includes parts that function as a therapist and leader in a mental health niche space. We'll be sharing tips and tools that have helped us and many others, while also sharing insights from our own journey of living with the condition. We'll also be hosting guests for conversations to help educate, dispel myths, and most especially help those living with dissociative identities and professionals who treat the condition. Thank you so much for tuning in. And now, let's get healing. Welcome to episode 7, everyone. We are the system behind Healing My Parts, which includes parts that work together as a therapist and leader in a mental health niche space. And we are so excited to bring our friend and colleague, Angela Kaloudis, to you today. We've had a relationship for a period of time, sharing clients sometimes, and just sharing a friendship that's been really beautiful. So I'm super happy to bring her to all of you today. And welcome, Angela.
Thank you so much. Thank you so much for having me. I am so grateful and honored to be with all of you and talking about topics that are so special to me.
We're so appreciative. I wonder, let's start out by, what would you like people who are listening to know about you?
Okay, yeah. Wow, that's a big question. So, well, I'm Angela Kaloudis. I use she, her pronouns. I'm a mental health counselor, licensed mental health counselor. So I'm licensed. I started out my career in Massachusetts. Since then, I have moved to New York, and I'm licensed in both Mass and New York, as well as Vermont. It feels like a random state, but there's just not much. There's a lot of gaps in the treatment in Vermont. So I'm licensed in those 3 states. And I treat dissociation, DID, OSDD, eating disorders. And the past couple of years, I've formed a specialty in the perinatal mental health community. Those are my 3. Oh, of course, and trauma, but that goes along with it.
I'm curious, or I think I'm not the only one that's curious. How did you initially get interested in treating eating disorders? And how did you get interested in DID and OSDD and any actually dissociation-related disorder?
It's interesting you're asking me that question because I didn't, it's funny because like you and I have talked many times around like how graduate school doesn't really prep you for working with eating disorders or treating DID or SDD or any dissociative disorder. In fact, I believe that my professors, who are wonderful and I love them, but they skimmed through like the eating disorder part in the DSM and they skimmed through the dissociative disorder. And it was kind of this flare of like, oh, these are really rare. And like, you probably won't see this all that often in your practice. And so I was like, okay, well, interesting. Like, I have to know it, but I don't have to know it. Joke's on me. Because it is something that I wish I knew a lot earlier. So I have been around so I come from a Greek background and my family is all about like food is love, as most Greek or like very ethnic families are about. And, in college, I was around a lot of people who had traumatic experiences and eating disorder behaviors. And I was really interested in what was happening. And like a lot of people were fascinated by behaviors. And I don't like to use that word like fascination. I was really like emotionally pained to see someone suffering. And so that when I went to grad school, I looked at the list of like practicum students and practicum placements. And I said, maybe I will try an eating disorder placement. And again, like dissociation wasn't even part of the idea, and how we treated eating disorders over a decade ago, like how I was formerly trained, is way different than how I treat them now. And it was so interesting because even in the eating disorder space, they were like, oh, we'd hardly ever see a dissociative disorder. And then I was really so now fast forward, I was in the higher level of care space for a long time, and I still am. And I would see a lot of clients who would come in and out of treatment, and they often would come with many diagnoses, eating disorder being part of it, but lots of other diagnoses. And it wasn't until I got EMDR trained So now we're fast forwarding to 2018. And at that point, I had been treating eating disorders and higher level of care since 2013. So maybe like 6 years. And again, we don't really talk about DID or OSDD until I was sitting in my EMDR consultation group, and my consultant, we went around the room, and she was like, "Oh, I want to know like what you specialize in, like what kind of therapist are you? What do you treat?" And so I said I treat eating disorders, and then she pauses and she goes, "Oh, so you must see a lot of dissociation like that." And I was like, I do see a lot of PTSD and trauma, but even when she was going through her specialties about like treating DID or STD, I literally like my brain was like, "Oh, that's not me." Yeah, like I don't treat that. I don't know how to treat that, but I did because I had experience with it. It just wasn't labeled that way to me prior to this experience. And so she's like, "Oh no, you do. You see it." And so honestly, like I remember I left that session and I texted a really good colleague of mine. I said, "Oh my gosh, do you think that all of the clients that we have seen, that we have failed them because we are only treating their eating disorder and not the dissociation?" And she was like, "Well, tell me more about that. What do you mean?" And so I was saying, and she was like, I was saying like, yeah, maybe like what was really happening was that we were treating like the wrong thing in the wrong context. Because we would see like different parts and their relationship with eating. I was like, wait, this is so confusing, because like on another day, another hour, their relationship with food can switch and change. And she's like, "Well, that makes a lot of sense." And I was like, whoa, I feel like my world just opened up. And that was when I got to reading. I read like anything that you could read about dissociation. And then I started talking. I think you and I had a conversation, and I think you were the first person to also say like, "Hey, have you ever thought about like treating like DID and like learning from someone with lived experience?" And I was like, you know what? Like, I think that's a really great idea, because I was reading all these books written by people without DID or STD, and I think there is like it was really helpful for me actually as like a clinician, newer to actually knowing that I was treating DID or STD. But that was when really like I was like, I have been treating this for years, a decade, and I just didn't know it. But once I felt more like competent and confident and like seeking supervision, seeking consultation, learning from people with lived experience, I really felt more like able, to do that. So.
It's so interesting that you had brought up, do you think the people that aren't getting better, from their eating disorders, maybe this is what we missed? So I can't remember if I told you this, but a couple of months ago, which is probably like 4 or 5 months. I mean, what's time anyway? It's just nebulous. But that I was looking up some research, getting some statistics, and I ran across these 3 journal articles that were in pretty well-known psychology journals from the 90s. One was like literally 1990. I think the others were 93, 94-ish, possibly 93. Anyway, what all 3 of these articles said was, if you have a client with an eating disorder who is not responding to standard treatment protocols for eating disorders, screen them for, at that time, it was multiple personality disorder. So screen them for empathy. They were finding that the bulk of the people that were not responding to treatment actually did meet that criteria, had that disorder. And when they got treatment for it, lo and behold, not only did their life become more fluid,
Yes.
their quality of life went up, but their eating disorders started to heal and respond to care. So I was like, how is it? I mean, I'm a fossil, right? I've been in this field for a long time. And I'm like, how did I not know that those journal articles existed? Why are we not talking about this? And how many people in the seed category may be in the seed category because they're dissociative?
Right. Or like we're so willing to slap on so many different diagnoses before even looking at a dissociative disorder, or that like we code it as so rare, or like it's a disorder that people are like, "Are you sure they really have it?" I'm like, what do you mean? Do you do that for major depression? Do you do that for generalized anxiety disorder? Like, do you really think they have generalized anxiety disorder. Like I have no one has ever questioned that diagnosis. But one like, oh, we would prefer to kind of slap on 6 diagnoses on someone before even looking at a dissociative disorder, or like, you know, it's interesting because even reading like some clients would bring like previous therapist notes into session and we would go through them. And a lot of them would be like, client would look childlike, told client to be more adult like, something like that. And it's like, interesting. Did they assess for dissociation in that moment? Probably no. The answer is usually no, you know.
This is also making me think about people that come into the therapy room and say, so I think I might have DID, or I think I might have OSDD. I think there might be other people inside, and how immediately they can be dismissed. You're watching too much TV, you've spent too much time on TikTok. That's really, really rare. And yet, fascinating to me. When somebody comes in and we suspect psychosis, we don't say, could you kindly prove that you are having this hallucination?
Right.
And we're asking people to prove that they have other parts of themselves. It's just a very strange way that we've gone about managing care for people. And pulling, and I know you know this already, but it bears repeating, this whole like it's rare thing. When you pull the actual statistics of DID, it's 1 to 1.5% global prevalence, right? OSDD1, which is basically the closest to DID, is 4.2%. Right, so we're talking about anywhere from 5.2 to 5.7% of the global population has this condition. And that it turns out the global prevalence of depression is 5.2.
Yeah.
And nobody's saying that's rare.
Right.
It's such a strange thing. I'm curious though, like, so now that you've been kind of treating DID and OSDD for a while, what do you wish you had known from the beginning?
One, I think, well, speaking on the how rare it is, that it's not that rare. I think that there was a lot of fear instilled, right? That like what we would actually see, like we would actually see people like, I don't know, like Sybil comes to mind, or like, you know, that these were always like the movies that were referenced in terms of DID, or again, like as what it was called, multiple personality disorder at that time. And I wish people would be like, it's not that rare. You might see this. And here are some things that you might see. Honestly, like you can get specialized training, you can consult. I think a lot of people fear it.
Yeah.
Right. Like I don't treat it, but like there's nothing special that I do in session. I'm not like, you know, I educate. But like my clients educate me, because when I don't have lived experience, and like even if I did, my experience and my client's experience can be wildly different, you know, as they typically are. And so like it's so interesting because like all my clients who are on the dissociative disorder spectrum, they just want someone to not be scared of them. They are sometimes scared of themselves, oftentimes in the beginning, right? They're like, I don't want this. This scares me. This scares my family members. Does this scare you? Like, you know, so I wish someone told me that it's not that rare, and that when you see it in front of you, it's not what you see in the movies, and that people just want to be heard and listened to. And there's a lot that you can learn just by listening and asking questions, and like offering some like slight education, which can come with good supervision and consultation.
Oh gosh, yeah, 100%. I'm just thinking about, I have so much gratitude and respect for you in providing a safe place for your clients to be able to show up authentically, because we both know that's not the case in a lot of therapy rooms, right? Where there's only one part of that person that's allowed to show up, and it can be really exhausting and challenging to mask your whole entire life and try to present a way that somebody, I guess, expects you to present, rather than just being like, can I just bring my mess in and can we figure this out together?
Yeah.
Can you help me find ways to develop compassion and skills and communication and collaboration so that my life looks better? So I'm, like you said, like, so I'm also not afraid of myself.
Yeah, right. or like I don't want to forget, I want to remember. And like, let's think of strategies to work on the amnesia piece. Like, let's work on strategies on like healing these other parts and like showing up for them, you know? Like, it's so interesting because like the therapy isn't so different. Like, we're showing up and like taking care of ourselves. And for people with DID, OSDD, like it's their parts.
Mm-hmm.
Right? They're authors. Like the people, like that's how do they show up for what they need, and like listen to them and have like board meetings or like, you know, like meeting place, like things like how do we show compassion for those parts?
In so many ways, I feel like this is me going off on a little tangent. Shocking, I know, but work, you know, being able to build inner worlds for people who don't have them organically, to be able to begin getting parts communicating with each other. And when things actually start to click and parts begin to respect each other and share space in the body so that so life in general is working better, like magic starts to happen. And it's
Yeah.
when we come at it, I think from this strengths-based perspective of this really is a creative, brilliant way of surviving some really horrible things, maybe a lot of really horrible things. And when we respect it for what it is and appreciate that creativity and brilliance, that strengths-based respect and compassionate view is so healing versus being on the receiving end of somebody that's kind of like, I'm just going to call it that medical model pathologizing, right? Where you feel a little bit more like there's something wrong with you. You're under a microscope. Everything's quote unquote maladaptive or bad. And you need to, I don't know, you need to somehow fix yourself.
Right.
That feels kind of gross to be on the receiving end of versus somebody who can really just appreciate the brilliance of your system.
Right. Right. And their strengths.
One of the things that I think a lot of people, especially clinicians who might be listening, will be curious about is this is what I've heard historically from people like, well, if they have DID or OSDD, that should be obvious. Like we would just pick it up. And yet we know, right, it takes 6 to 10 years to get a diagnosis for a lot of people. So people are not getting the care that they need sooner, which would be really beneficial for them and how their lives work. What are some kind of like red flags that you see that might tell somebody like, I maybe need to do a deeper dive into history taking, symptoms, to there might be actually DID or OSDD going on here right now?
Yeah. Yeah. Well, like I had said in the beginning, I treat eating disorders, right? And so for folks who do, even for folks who don't, I guess like as you were talking and I was thinking about my answer, I was thinking about what are some ways that people show up in the office for me and or like their report. And often it's when behaviors might feel like inconsistent or like there's no pattern maybe to like the therapist, right? There's like, you know, there's sometimes that there are situations that are like activating or triggering and there's a behavior that follows. And so there's a pattern or a theme. But when I see or sense any level of dissociation, usually the theme or the pattern isn't there, or there isn't much of one. Or maybe in like certain contexts there is, but not in all contexts. So if I'm like left feeling, I'm a little confused, I'm trying to figure out if there is a theme or a pattern. I'll ask my client, like, is there a theme here? Is there a pattern? And, you know, or I'll ask like, who's around when this happens? Or like, where are you when this happens? And if it's like at school, and then if it's like a different behavior when they're at home, you know, like asking those, like just remaining curious. And if it feels like it's too inconsistent, I'm like, okay, like maybe I'll do more of a deep dive. You and I have talked about how certain parts are the ones that go to therapy. And certain parts are also like, even if I do sense dissociation, a certain part could be filling out the MID, you know, so like it's important to like also recognize that like I might only see one part in my office, the part that goes to therapy. So it is important, like as I'm doing a deep dive, to ask about other settings. How would your partner describe you? Or like, how would your family member describe you? Like, have you noticed any, like if, of course, if amnesia is there, but not everyone with a dissociative disorder has amnesia. I'll ask more about like how are certain instances where you're like acting differently, or even like glimpses in the therapy room of like just like more like childlike, or just a different like way of speaking, or like sometimes I'll be the receiving end of some emails, and like the way that someone types might be different from one day to the next. So these are like just some like small glimpses that I think therapists, psychiatrists, medical providers are quick to pathologize, like, oh, like this is so weird, like this isn't like them, they're under the influence, or like, you know, there's quick to like name something else rather than remaining curious as to if maybe there's more dissociation happening in that moment.
Yeah, those are great things to look at. I know one of the things that you might find, I forget if I've told you this before, but I don't think people listening know. One of the things that was really amusing to me is that the first person that I ever treated with DID, I totally missed it. And people think it's funny, right? Because I had it, but everybody's different. You know, it looks different. And that was not my specialty area at the time. And so I started seeking consultation, because that's what we do, right? If we're going to be responsible
That's what we do.
therapists, that's what we do. And she also, the provider who does have the specialty, gave me a couple of other things. She said, you know, whenever you're sitting with a client and you feel confused, which is something that you brought up, think dissociation. And also, when you have someone who has been in treatment for a while and kind of nothing works, maybe they have like fistfuls of, you know, psych meds that they've taken and multiple treatments, maybe it's ECTs, maybe it's multiple hospitalizations, but nothing sort of fits. And they can sometimes get labeled as, quote, attention seeking, secondary gains, resistant to treatment. Those very unflattering and arguably unkind labels can pop up. That might be an indication to go a little bit deeper. And treatment teams who can't agree on a diagnosis.
Yeah.
And hopefully helping people understand it's really nothing to be afraid of. There's a whole umbrella of kind of levels of functioning underneath the dissociative umbrella.
Absolutely. I mean, I think about when I first started the field and how much dissociation we all missed because the person's not present in the way that, again, textbooks or movies showcase DID. And it's really, I mean, like, you know, sometimes when you look back and you're like, ooh, I'm a little cringy. Like that's me. Sometimes I'm like looking back, I'm like, oh gosh, you know, you don't know what you don't know. But like, oh, that intervention or that theory that I was working off of based on what I was taught. I wish I knew what I knew now.
Oh, amen about that. Wish I knew what I knew, right?
Yeah.
I think about things too, like amnesia, for example. You know, when you were saying not everybody has amnesia, one of the things that just personal experience was not recognizing that I had amnesia, right? Because what people would typically say is, are you missing like 5 to 10 years out of your childhood? And for me, the answer is, oh no, nope. Mm-hmm. Am I missing some things? Sure. But then arguably so is everybody, right? We don't remember everything in our lifespan. What became interesting after becoming more open to the, you know, may have had some acceptance issues with this diagnosis over time. Anyway.
Which is common, right?
So like, yeah, it's not a lot of fun to get in many ways. It was very easy to dismiss things that happened many years ago as just dismiss it. And I don't know, that was a crazy time period. I have no idea why I did those things. I still don't believe I did some of those things or whatever, right? Moving on with life. But becoming more like building that awareness and becoming more aware of having the reaction of someone sharing memories that I was included in. And my internal reaction was, God, their memory sucks. That wasn't me. Like, I don't know who the hell they're talking about, but that wasn't me. Or having another response frequently to someone speaking, which is like, why are they gaslighting me? Like they said, we've talked about this before. We absolutely have never had this conversation before. My memory's pretty good. And realizing that there was so much of that happening that maybe there was something wrong. Maybe not everybody else's memory sucked. Maybe the entire world was not gaslighting me.
Right. Yeah.
And nobody else was watching my next Netflix account. Maybe it was actually a part of me that was watching the Netflix account. Like, who the heck?
Right.
We joke around here.
Yeah.
I did at one point accuse my husband of watching the Harry and Meghan series in Netflix. I'm like, you could have at least put it back. I've lost where I'm at in the series. And he's like, dude, I don't watch Harry and Meghan. Like, I watch all those violent things that you don't want to hear. I'm like, oh crap. Okay.
Yeah.
It's
Yeah.
not that obvious. And people seem to think that, I mean, I know it is for some people, they're gone for weeks at a time and it is very obvious to them, but there's so many other subtle ways that amnesia can show up and it's so easy to miss.
Well, and some people are so resourceful that they have accommodated for their amnesia, right? Like post-it notes, like just like over time, like whether it remained diagnosed or undiagnosed, like there are certain things that people have done to like remember. And so notes, pages, journals, post-it notes. I mean, there's like so many things that people have done because they're like, oh, that's so interesting. I just can't remember. And it's like dissociation has never been in the conversation because they are remembering, but they have to look at like their previous notes in order to remember. It's missed. And I think honestly, like on this topic in conversation with other clinicians, like other clinicians can get really defensive. Like, well, I told the client this and they're telling me now that they forgot. And like, it's not my problem. And I'm like, it's like no one's fault, but have we like asked what may have happened throughout the week? Or, again, it goes back to curiosity around all of that. Because clinicians like, well, it's not my problem that they don't remember. I was like, well, maybe you can like send an email or you can like, whatever works related to like the therapist boundaries, right? Or like, right, hey, this is what we talked about. Just so you could have for the next session or something and see if that works. Yeah, there's just a lot of I noticed like a lot of like defensiveness from clinicians related to that.
It's so disappointing is the word I'm going to use, how quick some clinicians can be at just being negative around a client experience, right? Deciding that the client isn't invested or isn't motivated or it's fill in the blank, something that, or maybe the client is manipulative. Like there's so many negative words that sometimes get used instead of exactly what you're talking about. Can we put on a lens of curiosity and sort of be like, I wonder why this person isn't remembering? What else might be going on here? And can we help brainstorm a system that might work for that person to remember things like appointments? Have we tried phone alarms? And sometimes like phone alarms don't work. I know I have parts that would just like swipe up, because they don't identify with having a body. And so there are things that it's just, like, I'm just going to make this noise go away. And so having, sort of rules in place to get that cooperation and collaboration, which is if the part can't do what the alarm says, then it has to get a part that can to get that collaboration going. Yeah. That is something that I wish somebody had talked about 30 years ago, would have made life a lot easier. It's relatively simple, but if the lens is negative and we're constantly blaming clients for things not working well, we're not going to get very far. And then the person's healing is stymied.
Yeah. Or like trying to fit a certain protocol.
Yeah.
Within that person. Right. Cause like, I'm just thinking about eating sort of protocols too, like, or what the treatment plan might be, and like not adjusting that based on what the client is bringing forward. I'm thinking about like, amnesia gets missed, but in so many eating disorder spaces, like, these are, there's no accommodations for parts and like their preferences. And yeah, I feel like that's also a part of it.
Eating disorder treatment has been remarkably rigid for decades. And while I think that at least there are providers where it's getting a little bit better, overall, if you look all over at least the United States, treatment remains pretty rigid on the whole. So it's kind of nice to hear some providers. We have a whole new subset coming up, the younger providers who are definitely shaking things up in a really beautiful way. So hopefully things are changing. And you're certainly part of that, which is really great to see. I'm really hopeful for the future for folks who are struggling with eating disorders and also who are in that intersection, right, of DID, OSDD, eating disorders. Well, that actually begs a question, right? What do you wish therapists who treat eating disorders knew about the OSDD?
Okay, I wish that they knew what to look for, and that we can treat it. an eating disorder specialist professional can treat dissociative disorders with the right guidance and like some and flexibility. Because again, like to speak to like the rigidity around the eating disorder field, I think that doesn't mean that we don't challenge our clients. Believe me, my clients would tell you, even if they listen to this podcast, they'd be like, Angela challenges me. Angela like does like, I'm not saying that we should be totally like, oh, whatever like goes, whatever goes, right? Like there could be some like guardrails on the treatment. And like we have to come at it with flexibility. Like it's up to the client to talk about like what they're willing to eat, like how much of it. And like I'm pretty opinionated. My clients will also tell you that. Like in the room, like there is no reading between the lines with me. And if I'm confused, I'm going to say, I'm confused. you know, like and like not all parts love that part, and that's fine. You know, it's like we talk to the parts that maybe have a reaction to me like being like challenging, and that's fine too. I just think that like I wish the eating disorder field was open and willing and flexible on some things, while also like operating in the way that, you know, we know can help, and just like this and saying that in collaboration with our clients and their parts. Like I think that like that's like just why can't we collaborate with our clients instead of being like, hey, I'm the expert in the room.
Oh, that just, when you said that, you just gave me the grossest feeling when somebody's like, I'm the expert in the room, because it just is so dismissive of the client's knowledge, life experience.
Yeah.
They're the experts on themselves.
Yes. Listen, I'm going to tell you what I know, and this is what I think should happen. This is what I would like to happen. Like, how do we get there? How, and this is why, you know, like so many times we just say these like things, and it's like, I just follow what I say. People are like, why? Like, I wouldn't do that. I don't. Like, as a client, I'm like, I need you to tell me like why you're telling me to do this, you know? And I think that we have to tell our, like with anything that we say, you know? So I wish like eating disorder professionals, I guess that's the takeaway, is that like we want not to be so afraid. Like we're not dealing with monsters. Like this is like, it feels really, dehumanizing when people say like I don't work with dissociation, I don't work with DID or SDD. Like you do. If you work with trauma, you do work with dissociation. If you work with eating disorders, you absolutely work with dissociation. And I think people being open and willing for that crossover, whether or not they specialize it or not, like they're seeing it, they're just not giving their clients the right treatment.
Oh, you're just making me think about a couple of eating disorder providers that I've overheard and also have had conversations with, where they're like, I don't know if DID is a thing.
Yeah. I feel so protective because it is a thing. And like that, it honestly, like it really makes me so upset to hear that.
Yeah. I'm just thinking about all of the people who aren't getting care because somebody is questioning the existence of a diagnosis that has been around for hundreds of years, has been identified in every country. There was recently somebody who said, oh, well, you know, like, what if it's a misdiagnosis? Like that can be really damaging. Like so any misdiagnosis is going to be harmful to a degree, but you know, not diagnosing something like this and preventing people from getting care that they need seems far more harmful. And if it really is a misdiagnosis, you're going to figure it out. You know, it's not going to take you that long to figure it out.
Right.
That's disappointing, you know, it's that's where we're at in the field to some degree. On the flip side, like, what do you wish people who, like therapists who specialize in trauma and who treat DID, OSDD, knew about eating disorder?
Many times I would also talk about this in like my supervision consultation group, that I feel like I'm on an island. Because like, you know, it used the TikTok, like Instagram reels of like the people who are like, oh, you go one way and there's like a block, and you go another way and there's a block. That's how I feel with the eating disorder field and the trauma field, because it's like, I'm an eating disorder specialist and I treat dissociation. We don't do that here. I am a trauma specialist. I treat eating disorders. We don't do that here. And I'm like, what? I'm like on this island by myself sometimes, and I with other eating disorders and trauma specialists. But it's just really interesting because all like most of the trauma specialists that I have talked to who don't who I've not met in the eating disorder, I guess, like sphere, through like EMDR trainings or like somatic experiencing trainings or, trauma trainings, like they are like, oh, I refer out for all eating disorders. Like, how do you do that though? Because there's such an overlap. And so, and like some of the recommendations in like for trauma is like, oh, like exercise or like do these things. And I'm like, oh, sure. Like that certainly can be regulating, but have we screened how they're using those things? And are you adding fuel to another fire? You might be putting out one, but are you adding to another? And are you just asking the question? I'm not saying the recommendation changes, but are we asking the right questions? And it's like, yeah, there's some trauma specialists who are like, oh, eating disorders are only a form of dissociation. And I have some issues with the absolutes related to that too. So
yeah,
I wish trauma specialists, it's just like, I wish trauma specialists were more open to getting eating disorder training because, they're like, oh, no, like you can't treat that if you can't treat it with like EMDR, you can't treat it with like these modalities. And I'm like, oh, you can, you just need to make sure that you're like asking the right questions. So yeah, my eating disorder DIDS OSDD clients are like, it's taken them years to get to me because they get into a roadblock of an eating disorder specialist not working with DID or a DID dissociative trauma specialist not working with eating disorders. And so they're like ping-ponging from treatment programs.
It's so crazy how we compartmentalize care. It's driven me crazy, and this, like for a really long time, especially having led like higher levels of care, excuse me, for eating disorders where, it's like, oh, well, we don't treat trauma. And then you get the eating disorder stable in the person and you send them out.
Right.
And they get their trauma treatment, and then their eating disorder symptoms destabilize, and then they're back in eating disorder treatment to get stable, to go back out to do more trauma treatment it's crazy. It's like this turnstile. Yeah. Why can't we holistically treat humans? And I can appreciate the fact that not every provider can be an expert in every single disorder, but there's a basic skill set, right? At least for eating disorders, a very basic skill set that pretty much everybody can master to help clients progress and move forward. And over time, you can slowly build your expertise. And there are such good places to get training, to get consultation. There's a lot of resources out there. It's not that difficult. I almost feel like eating disorder knowledge is actually more accessible than DID knowledge.
I would agree with that. Yeah. Yeah, I would definitely. I mean, there are more people open about treating eating disorders, I think, than treating DID, OSDD from my experience, but also reported experience too.
Yeah. I mean, just thinking about what's available there's definitely trainings and there's certainly books and there are definitely consultants out there. Not necessarily as easy to find.
Yeah. For DID or for both?
I think for DID, it's harder to find than it is for eating disorders. I feel like it's not that challenging to find a consultant to work with around an eating disorder.
Yes.
Pretty easy to find conferences where you can learn and organizations who can point you in the right direction versus, for DID, I mean, quick and important shout out to Dr. Jamie Marich for founding ICM, where she has consultants that are affordable, and she has trainings that are affordable.
Right.
And she's written plenty of books that are accessible. So shout out to her for being a leader in that field. And I know lots of folks also get training from SSTD. And actually, I'm curious, like, what are your favorite recommendations for folks if you're a therapist and you're looking for like, how can I get some training in DID?
I would actually say, you already mentioned Jamie Marich's book, Dissociation Made Simple but that one came out recently. So that was more like confirming and also teaching me from lived experience. But there's also Suzette Boone, Coping with Dissociation kind of workbook that I think I learned a lot just like in basic definitions and like what to look out for. I think for a clinician like me, like really there's so much out there. And I really needed something to be like, hey, here are like the facts, like this is what this is what it looks like. And then the Finding Solid Ground workbook has been like a game changer for me in my practice. And that I absolutely love that book. I refer to it a lot. The anchoring practices, the grounding practices, orienting here and now, like safety. And I think part of people's reservation is a safety piece, honestly, because like a lot of clinicians are like, well, like, how do I maintain safety first? And I'm like, okay, well, like, how do you deal with chronic suicidal ideation? Like, it's no different. There are some people who will always have thoughts, right? And like, how do we work with them? And even in the context of dissociation, how do we keep people safe enough, right, to come to therapy to talk about it? And that's like, something that I've learned actually from people from lived experience. Because a lot of the books are like, first step is maintaining and establishing safety. But there are so many people who we have to reach safe enough, safe and full safety may not be achieved based on like their living situation or like really grieving their past and like, recovering from really horrible things. So I am part of the ISTD, and I joined the eating disorder dissociation list. Like it's like a small little subset. We have like an email going, and I have learned a lot from them. And there are like monthly meetings that I attend, and I have found that really helpful. And yeah, I think for a clinician, like really trying to understand, like that's where I would point them to, like those three things, like the listserv, coping with trauma-related dissociation. Jerry Marriage is like wonderful in terms of like her Instagram and her like their books and the things that they have written. So Institute of Creative Mindfulness, Amy Wagner, so there's so many great people that we could learn from. So the information is out there. It's not a lot, but there are resources. But I would say the most impactful is consultation.
Which is such a great avenue for learning because it's so highly individualized, right?
Yeah. Yeah.
I think the only thing that I would probably toss in there, for folks is if they want to learn from lived experience is to also check out an Infinite Minds Healing Together conference where you have professionals with lived experience and then with lived experience and the supporters all coming together. It's a really big event, but there's some really, really fantastic information across the board.
I love that. Yes.
To help people conceptualize it differently.
Yeah. And they have a virtual part of it too. Like it's an in-person and virtual, right? Yeah.
And it's pretty much split. I don't know what the grand total was for this past year, but I know there was like 402 in person. And then I think it was just under 800 attending. So like half and about 50, I think she said 51% had lived experience at the conference.
So cool.
So yeah, it's a pretty neat place. So I'm curious what advice you might have for somebody who's seeking care. Somebody who's like, I have DID, OSDD, or I think I do, and maybe I have an eating disorder, maybe I don't. Like, how do I go about finding somebody? How do I know if the person is good?
Yeah. One, it is so hard. So I would just tell them that they are seen and that they shouldn't just stop at the first person that they see if they don't get a good sense of them. There are like, of course, Meta is always my first go-to resource, but I would reach out to like people who treat both, just like one name, and then see if they have referrals for other people. Because again, like a clinician is likely, should be getting supervision and consultation on the things that they are treating. And so hopefully they have built some sort of like master list of people who also treat and can help guide. Because I would say that's what most established care has come from. Like my name has been given from a colleague of mine in the same consultation group, from someone who reached out to them wanting that. I've joined like that, again, the trauma and dissociation, like listserv, which a lot of my current DID and OSDD clients have found me, and they found me because of specializing in both. So it's hard to find someone who will treat both. So I just want to validate that. And like, I also want to validate that it might be really tiring and discouraging sometimes when you are hitting roadblocks around people who don't treat both or don't treat both well. But it is possible to find at least one person that can give you a name, and then you reach out to them and they can give you more names,
That's great advice.
So yeah, because there isn't, I wish there was like a master list, like, or a place where, but there isn't, and it's very few and far between. And depending on the state that you're in and like where you're listening from, like it varies greatly.
Yeah. And it's different all over the world too, right? The system in the UK is really different from the system in the US,
Yes.
from Australia, New Zealand. So
Right.
there's a lot to navigate. I will say, I do feel like people who are in the DID community, either with lived experience or as providers, tend to be really responsive if you reach out, even if they can't personally be helpful. They're really good at sharing resources.
I would say, yes. I would say actually for both the eating disorder field and the DID field, like that is true for both. In terms of like, hey, like I can't treat you because I'm licensed in this state, or I don't know how it works in Australia or the UK or whatever, or wherever you are in, but let me see in my network if I could find you someone, and I think that would be my best advice. Because I would also like say, oh, look up, on this list, but some people don't get back to you, or there's like word of mouth and like direct referrals often land better in terms of success. So
this has been a really great conversation that I think is going to help a lot. And I wonder, like, any final thoughts, anything that you would like anybody to know?
Well, there's so many things that I want people to know, but I guess I'm like really still thinking about like the folks who meet others who don't believe that a diagnosis exists. It's like really, I don't know. Like I know that was true, and like you just saying that again, I'm like, oh gosh, like it hurts my heart, honestly. I guess like speaking to the clinicians, I'll speak to both. I'll speak to the clinicians with or without lived experience, but maybe like this is specific for clinicians who are trying to learn about treating OSDD or DID, that there are people that we can learn from, and there are resources available. And you might need to collaborate. You might need to do some education after you have had your own education on the other people on the team. There are many times that I've had to talk to psychiatrists or dietitians and correct the record, depending on their like school of thought. Medical providers who are like, oh, you don't dissociate, or like, you're just attached to another diagnosis type of narrative. And you might have to do some education. So I think that's like a tricky part to navigate for a lot of folks, especially who are maybe the folks listening are already treating eating disorders and they want to learn more about dissociative disorders. That correcting the record has been like, I should probably put it on my resume, to be completely honest. Yeah, a skill, exactly. It's like, it's interesting how many people don't really know like what I mean when I say dissociation. So
I think the colloquial understanding of it, right, is somebody just quote unquote spacing out, staring off into space and being unresponsive.
Daydreaming, or like completely like freezing, and there's like two separate ways. It's like one extreme to another. It's like, oh, someone is completely like shaking in the corner and like, or they're just like spacing out. And then like, actually there's a bot in the middle between those 2 points. That could happen, that might be showing up. It's like, what do you mean? They're just, there's a lot of misconceptions around it, in the medical community, especially. So that's like something that I often talk to supervisees about too, is like, you might need to, because like the eating disorder field, there's a lot of collaboration, right? Because a lot can change with our dissociative clients. So you might need to get on the phone and do some education for the other providers, so that way they're not unraveling, I guess, some of the things that you're doing in session.
Like, don't be afraid to advocate for your client, right? You can sometimes be the strongest voice to make things go smoothly for them.
Yep.
It can be like a skill on LinkedIn, don't you think? Like correcting the record and client advocacy, and then we can just endorse people for it, because it's so important.
Yeah, right. And it's like, I don't want to step on their toes. I'm like, okay, but we're moving away from who we're trying to advocate for, and that's our clients.
Yeah.
Who have probably had many years, if not internally, but also externally been invalidated.
Oh gosh, it's so true. And recognizing that there's like this, and it feels like there's this inherent hierarchy sometimes in the field. And so understanding that you're whoever you are, whether you are, a therapist, nurse practitioner, a dietitian, it doesn't, your voice is equally important as a physician.
Yeah.
You can often make the biggest difference by using your voice on behalf of your clients, and don't be afraid to do that.
Yeah. I mean, I've had wonderful conversations with physicians and psychiatrists too once we get on the phone. I think I like to take the stance of, you didn't learn this in medical school, and I didn't learn this in grad school. And I wish someone told me. And, some physicians and some psychiatrists are more open. But I have been really lucky at times to talk to some psychiatrists for that is really helpful to hear from you. So you don't know the impact, and I like to give bullet points of here's what you can do to kind of support our work, whether or not I'm not going to get into a battle around do you agree or do you not agree? I can't change someone's mind. So I was what can I do though? I can set a bullet point list as to here's how to support the work that I'm doing. Whether or not you agree with the diagnosis that I'm providing this person, this is how you cannot do more harm. And maybe that we can agree on you supporting the work.
That is great language for people. So for folks who are sort of I want to advocate, I want to call, I want to be a voice for this client, but I don't know exactly how to say it. I think you just gave people some really critical language that they can use.
I'm hoping that's the case, right? Yeah. Because people are I don't know what to say. They're still not believing me. And I'm we're not up to bat here. I will do what I can with my clients that would they feel the most supported. For the clients who are wanting, or people wanting to be clients or needing a therapist, there are therapists out there who will believe you. So we just need to find the right fit. But I'm not getting into a battle. I'm not up to bat here, but here's what I need from, this is what I'm asking. And that's kind of the takeaway. It's this is what we're going to focus on.
Well, this has been great. Thank you so much.
Thank you.
I think it's going to be helpful for so many people.
I hope so. I appreciate the time.
For everyone listening, we hope this conversation has been helpful for you. If you are somebody navigating the intersection of DID and eating disorders, we hope that you know you're not alone. Whether you are a therapist or somebody navigating that space, please feel free to check out the show notes for some additional resources, and feel free to reach out anytime through our Instagram account at healingmyparts, or email us at healingmyparts@gmail.com, or reach out to us through our Substack. Thank you so much for being here and for making this world a better place just by being in it. Until next time, let's keep healing. Thank you for tuning in. You can find our blog on Substack at healingmyparts.substack.com and on Instagram at healingmyparts. Just a disclaimer, any information shared in this podcast is not a substitute for professional therapy or behavioral health care. Nor does listening to the podcast constitute a therapist-client relationship. Please be sure to take extra good care of you. And until next time, keep healing and thriving.